I'm Dr. Hugh Hagan with the section of hand surgery, Carilion Clinic, Department of Orthopedics at the Virginia Tech Carilion School of Medicine in Roanoke, Virginia. And my charge today is to discuss injuries around the thumb metacarpal. We'll discuss the anatomy of the thumb, CMC, and MCP joints. We'll discuss diagnosis and treatment of common injuries to the thumb, CMC, and MCP joints. We'll discuss salvage treatment of injuries that fail primary treatment or that are picked up late. So, what's so great about having a thumb anyway? Evolution of the primate hand over the last 15 million years has allowed improved prehension and in-hand manipulation. With increased reasoning and cognitive ability, the thumb has evolved to allow improved manipulation of the surrounding environment and has enabled fabrication and use of tools. The more advanced the primate, the greater the ratio of thumb length to finger length, and the better developed the thenar muscles become. As is shown in the drawing on the right, the chimpanzee who has a thumb has a diminutive thumb compared to the human hand. The longer the thumb and the larger the thenar muscles, the greater the degree of freedom is possible, the more precise the prehension, the easier in-hand manipulation. Independent function of the thumb requires both mobility and stability. The CMC joint has more mobility with less stability, and the MCP joint has more stability and less mobility. The combined contribution of these two joints of the thumb allow cooperative, flexible, precise function over a wide range of activities. The goal of treatment is a stable, painless metacarpal phalangeal joint and a mobile, painless CMC joint. Let's look at each joint. The CMC joint, which is comprised of the base of the thumb metacarpal and the distal articular surface of the trapezium, is two saddle-shaped surfaces turned 90 degrees to one another, forming a universal joint. It behaves much like a ball and socket would, but it is not a ball and socket joint. The stability of this joint depends upon the soft tissue constraints around it. This would include the dorsal radial ligament and the anterior oblique ligament and muscle and tendon attachments around the joint. The MCP joint is convex distal metacarpal proximally and concave proximal phalanx distally. It is a hinge joint. Stability is a combination of joint congruity, volar plate, collateral ligament, and muscle and tendon attachments. Muscle and tendon attachments around the thumb metacarpal include, for the CMC joint, the thenar muscles and the abductor pollicis longus tendon. For the metacarpal phalangeal joint, it includes the adductor pollicis, the abductor pollicis brevis, the flexor pollicis brevis, and the opponens pollicis, the last three of which comprise the thenar muscle mass, as well as the extensor pollicis brevis, as seen on the drawing on the lower right. Injuries around the thumb metacarpal include sprains, dislocations, and fractures. We'll take some time to discuss each of these in course. A sprain of the metacarpal phalangeal joint ligament and capsular injuries include two major types: the ulnar collateral ligament, otherwise known as gamekeeper thumb or skier's thumb, and the radial collateral ligament, which is sometimes referred to as Dorman's thumb. Dorsal dislocations can be either simple, i.e. no interposed soft tissue in the joint, or complex, in which the volar plate is interposed in the dislocation. Gamekeeper thumb will occur when the unprotected thumb is forced into radial abduction at the MCP joint. A grade 1 injury is simply a sprain, an intersubstance injury to the tissue. A grade 2 is a partial tear, but that has an endpoint with stress testing. A grade 3 is a complete tear. And two subsets of grade 3 injuries include the ligament being non-displaced, i.e. torn but adjacent to its normal point of insertion, or displaced. Certain displaced sprains can be complicated by displacement of the ulnar collateral ligament around, behind, and beneath the tendon of the adductor pollicis. This is sometimes called a Stenner lesion. As is demonstrated on the far right drawing, the distal portion of the ligament is entrapped and pushed away from its normal point of insertion, which prevents it from being able to heal normally. The MCP joint has two major contributions to ligament stability: the collateral ligament and the volar plate. The ulnar collateral ligament and volar plate both resist radial abduction. The ulnar collateral ligament resists abduction when the MCP joint is flexed, as is shown in Figure 1. The volar plate will also resist abduction when the MCP joint is extended, and this has some clinical implications when testing for stability after an injury to the ulnar side of the thumb. The diagnosis of gamekeeper thumb is made based on observation of bruising and swelling, tenderness over the ulnar collateral ligament, and pain over the ulnar collateral ligament with radial abduction. The degree of instability of the MCP joint with radial abduction can be assessed by radial stress testing. The ulnar collateral ligament and volar plate, as said before, both resist radial abduction. Some laxity, but an intact endpoint, indicates a grade 2 injury, something that will heal with non-surgical management. An endpoint with the MCP joint in extension, but not in flexion, indicates that the ulnar collateral ligament is damaged, but the volar plate is intact. When the volar plate is intact, it is far less likely that you would encounter a Stenner lesion, as is demonstrated in the drawings on the right. If there is instability with full extension and flexion, then the incidence of a Stenner lesion goes up significantly. In the drawings on the right, you can see the ulnar collateral ligament is entrapped underneath the adductor tendon. Is imaging helpful? Well, X-rays may show an avulsion fracture of the insertion of the ulnar collateral ligament. Usually, the location of this avulsion fragment will also coincide with the location of the distal ligament, though that is not universally true. This X-ray demonstrates a minimally displaced avulsion fracture, which will likely do well treated non-operatively. Ultrasound can be helpful. The upper right picture, Figure A and B, show an ultrasound image of an avulsion of the insertion of the ulnar collateral ligament of the MCP joint of the thumb. A shows an outline of the soft tissues over the ulnar side of the thumb, and B shows an outline of the ligament itself. C demonstrates a drawing of the same thing, where the ligament is actually entrapped underneath the adductor tendon, creating a Stenner lesion. MRI can be helpful. It is quite sensitive, but in this world of increasing facility with ultrasound, it may be overkill. Treatment of gamekeeper thumb. In grade 1, grade 2, and non-displaced grade 3 injuries, splinting, with or without transitioning to a cast for a period of 6 to 8 weeks, is effective. You need to be careful with the thumb for about 3 months. It takes a long time for this to become completely asymptomatic, but generally non-operative treatment in this setting is successful. Some non-displaced grade 3 injuries you may choose to fix surgically. All Stenner lesions you would choose to fix surgically if you can identify them, and fixation can be done in a variety of ways. The surgical approach for surgical care of a gamekeeper thumb includes a dorsal ulnar approach to the MP joint, taking care to avoid injury to the distal fibers of the radial sensory nerve, dividing the aponeurosis of the adductor pollicis, which exposes the ulnar side of the joint and the avulsed ulnar collateral ligament. You would prepare a footprint for the reattachment of the distal avulsion at the volar ulnar aspect of the proximal phalanx of the thumb. Attachment can be either with suture anchor or pull-out suture, and with or without augmentation using synthetic material. Pinning the joint in a corrected position is sometimes advisable. I think you have to pay attention to the quality of your repair and the cooperative nature of your patient in deciding whether or not a transarticular pin is necessary. I tend to have a low threshold for putting a pin across the joint. You protect these repairs for a minimum of 6 weeks in a splint. The radial collateral ligament sprain is less common, and treatment considerations are the same as the ulnar collateral ligament, except instability of pinch isn't a problem with injury to the radial collateral ligament generally. No Stenner lesion equivalent exists, so closed management is much more likely to succeed. And you might consider surgical repair for certain high-performance individuals, such as Division I athletes or professional athletes. Dislocations of the thumb MCP joint are relatively common. They are generally dorsal, as is demonstrated in this X-ray. They can be simple, i.e., no interposed soft tissue in the joint, or complex, interposed soft tissue in the joint. In the upper drawing, the thumb is hyperextended. The volar plate is avulsed from its normal origin, but it is not tucked into the joint. In the lower drawing, the volar plate is flipped around and is interposed in the joint. Simple dislocations generally look a lot worse than complex dislocations. Close reduction of an MCP dislocation of the thumb can be performed in simple dislocations by simply flexing the MP joint without distraction. Distraction of the joint can sometimes be rewarded by interposition of the volar plate, which turns it into a complex dislocation. Complex dislocations almost always need to be opened surgically. The surgical approach can be either dorsal, which provides a good look at the metacarpal head, or volar, which can provide a good look at the metacarpal head at the cost of having to open the flexor tendon sheath and be particularly aware of the location of the digital nerves. In the upper line drawing, the approach dorsally is demonstrated. You get a good look at the base of the proximal phalanx, and you can see the volar plate interposed. This can be split in its mid-substance, pushed volarly, and this will allow reduction of the joint. On the volar approach, a release of the A1 pulley can allow you to move the flexor tendon out of the way, but you have to be pretty cautious about the digital nerves. MCP dislocations, dorsal dislocations, are generally stable once they're reduced, whether you treat them open or closed. Thumb CMC dislocations are pretty rare, less than 1% of all hand injuries. The mechanism generally is an axial load to the thumb. Usually these are high energy injuries. Generally speaking, the dorsal radial ligament is going to be torn off the base of the proximal phalanx, off the base of the metacarpal. The anterior oblique ligament may not be completely torn, but rather stripped with a periosteal sleeve off the volar proximal segment of the metacarpal. Examination of patients that have CMC dislocations include swelling and bruising with adduction of the thumb and tenderness over the thumb CMC joint. X-ray generally will show dorsal displacement, perhaps with a fracture of the base of the metacarpal or the margin of the trapezium. X-ray on the right shows a pure dislocation. Treatment of thumb CMC dislocations can either be closed or open. Closed reduction, if achievable, is usually stable. The anterior oblique ligament is generally intact in this setting and can be used as a fulcrum to provide stability to the joint. Immobilization for 6 weeks with the CMC joint in extension, abduction, and pronation will lock the reduction in place. What if your closed reduction is unstable? Generally speaking, the anterior oblique ligament in this setting will not be intact, cannot be used as a fulcrum for maintaining stability, and this would require percutaneous pinning in the event that you can get a closed reduction, or open repair, reduction, and possibly reconstruction of the dorsal radial ligament. Fractures of the base of the thumb metacarpal are pretty common. They can be extraarticular. They can be a Bennett fracture, which is one small articular fragment attached to the intact anterior oblique ligament at the base of the metacarpal, or they can be complex, otherwise known as Rolando's or total articular fractures at the base of the metacarpal. Deforming forces around the base of the thumb metacarpal include the aforementioned stabilizers, which include the abductor pollicis longus, the extensor pollicis brevis, extensor pollicis longus, and the adductor pollicis. The abductor pollicis longus will tend to pull the metacarpal proximally and radially. The extensor pollicis longus and adductor pollicis tend to adduct the thumb, making the dislocation of the thumb easier or reduction more difficult to maintain. Extraarticular fractures are generally dorsally angulated. If you have a fracture that is dorsally angulated less than 30 degrees, the mobility of the CMC joint will allow simple splinting or casting in that position with the expectation that a good functional thumb will result. Here's an X-ray of a thumb extraarticular fracture that is displaced slightly dorsally and angulated dorsally. If deformity is over 30 degrees, then reduction in pinning or reduction in internal fixation might be considered, as in this X-ray on the right, where there is a considerable amount of dorsal angulation that was treated with plate and locking screws. The Bennett fracture, which is pretty common, is a fracture dislocation of the base of the metacarpal. Best thought of as a dislocation of the metacarpal with a small fragment of bone left attached. Here's an X-ray of a Bennett fracture in which you can see a rather large articular fragment remaining with the anterior oblique ligament and dislocation of the thumb metacarpal dorsally. The volar articular fragment will remain attached to the anterior oblique ligament. The remaining metacarpal base will dislocate. The dorsal radial ligament is generally torn, causing this to be an unstable injury. The pull of the abductor pollicis longus and the force of the adductor pollicis tend to adduct the thumb and pull it proximally, making maintenance of closed reduction difficult. Treatment of a Bennett fracture can be done in a variety of ways. In his classic book, The Closed Treatment of Common Fractures, Sir John Charley described the reduction technique and immobilization technique for Bennett fractures. Closed reduction and pinning is also a common form of treatment for Bennett fracture, depending on your ability to reduce and maintain reduction of the thumb metacarpal base. Open reduction and pinning, or open reduction and internal fixation, sometimes are necessary if closed reduction of the metacarpal base is prevented by interposed soft tissue or a delay in treatment. Closed reduction of the Bennett fracture requires longitudinal traction, pronation, and then maintenance of pressure over the base of the metacarpal. Longitudinal traction and pronation, you may recall, are the way that you can maintain a reduction of a reduced CMC dislocation. The CMC dislocation will tend to be more stable because of an intact anterior oblique ligament. In the case of a Bennett fracture, there is no attachment anteriorly to maintain the stability, so dorsal pressure over the base of the thumb metacarpal will be difficult. The goal is to have less than a 1 millimeter step off of the fracture line. Whether this is wishful thinking, I think just depends on how lucky you are. What makes an adequate closed reduction? Article in the British Journal of Hand Surgery in 1986 reviewed 25 patients. 22 of 25 were available for follow-up, 9.5-year follow-up on this retrospective study. And their conclusions were there was little evidence that an imperfect reduction would lead to significant symptomatic arthritis in the long run. In the Journal of Orthopedic Trauma in 1995, a similar study was done following closed reduction and casting of Bennett fractures. They had 20 of 22 patients follow up. They had a 13-year follow-up. 7 patients out of the 20 that followed up were arthritic and painful. These patients generally had an imperfect reduction, and thus an imperfect reduction was considered a prognostic factor for symptomatic post-traumatic arthritis of the CMC joint. In the x-rays on the right, the red line demonstrates the distal articular surface of the trapezium, and the tangent drawn with the margin of the trapezium shows alignment of the base of the thumb metacarpal with the trapezium. In the x-ray on the far right, the red line demonstrates the distal articular surface of the trapezium, but a tangent drawn there demonstrates dislocation of the base of the thumb metacarpal. The x-ray on the left might be considered acceptable if it's maintainable. The x-ray on the right, demonstrating a residual dislocation, would not be acceptable. So treatment of the Bennett fracture is less about the articular step-off at the fracture line and more about getting the metacarpal base reduced in a stable fashion. Reduction is going to be hard to maintain using Charnley's technique in the swollen and tender thumb. Therefore, closed management is usually also associated with pinning. Good metacarpal base reduction generally will lead to a satisfactory result, as demonstrated on the far right x-ray, where the fracture has healed and the metacarpal base remains congruent with the trapezium. Open reduction is sometimes necessary in the event that you cannot get a closed reduction of the metacarpal base, and this might occur as a result of soft tissue interposition or delay in treatment. The surgical approach is either a straight dorsal or a Wagner-type approach, and screws, pins, or a combination of the two can be used to achieve an anatomic reduction and maintain stability. The Rolando fracture is sort of a super Bennett fracture, but it is grossly unstable because of not only the discontinuity of the articular surface, but the general disruption of soft tissues. The goals are to try and achieve a congruent joint and to try and restore length of the thumb. Surgical management, assuming a suitable patient, would include closed reduction and pinning if the fragments are large enough and the fracture is treated soon enough. In my experience, this is relatively uncommon. Usually this will require some form of open treatment with pins or locking plate, or external fixation if the soft tissues will not allow the use of internal fixation, such as demonstrated in this line drawing. Salvaging failed cases of injuries to the base of the thumb metacarpal include ligament reconstruction for MCP joint dislocations, sometimes augmented, and arthrodesis of the joint using internal fixation as needed. The CMC joint is generally going to be treated with either an arthroplasty, as is demonstrated in the upper right-hand drawing, or fusion of the joint using a plate or pins and tension band wires, as is demonstrated in the lower right x-ray. So in summary, Injuries around the thumb metacarpal, MCP joint, and CMC joint are relatively common. Recall that the thumb is a mobile, stable, precise, and strong appendage. The treatment of MCP injuries should focus on maintaining position and stability, and treatment of CMC injuries should focus on maintaining position and mobility. Salvage procedures for the CMC and MCP joints are generally straightforward and predictable. Thanks very much for your attention.